with the support of all the state government and statistics of them in all, approved that a project which the table before them should be carried out between October 28th and November 3rd. It is ongoing right now, and as we talk, it is about project 10 million. They want to screen Nigerians free of charge of diabetes and hypertension. And it comes under know your number, then control your number. That is, once you know where you belong, you can begin to manage and control it. Because we are made to understand that this is not a curable disease so far. But my guest in the house will tell us whether it is curable or not, because I'm a layman in that aspect. I've been joined in the studio live now by the Commissioner for Health in Ogun State, one of the 36 commissioners of health in Nigeria that decided to come together and have this project for Nigerians so that people can know their health status. Join me as I welcome to the studio Dr. Tomi, Commissioner for Health Ogun State. You're welcome to the program.
Thank you for inviting me once again.
All right, let's begin on this note. We saw you carrying out similar exercise for the governor of Ogun State, Prince Abeokuta, in which you were taking his BP and the likes of that. Are they also part of the people that are supposed to benefit from this?
Absolutely. The project 10 million is for every single Nigerian. We just chose the number 10 million just to be able to put it into context, because we're aware that not every single person is going to come out. So the screening is for Nigerians, regardless of your socioeconomic status, regardless of your postcode, which if you're in urban area or rural area, it's for every single Nigerian. If you avail yourself, we'll be happy to take your blood pressure and test your blood sugar for free.
All right, okay. Now, 10 million, that is far cry from the population of Nigeria. How often would these projects be conducted?
So we do know that Nigeria had 220 million, and we know that the incidence from what we've been doing, hypertension from the people we've screened has been about 14%, and with diabetes between 5 and 6%. So if you take that, you'd expect that if we screen all Nigerians, all 220, that will get about 20 million of us. However, what we're trying to pick are people who have not been tested before and do not know. So there'll be people out of the 20 million that would have been tested before, and they know their status, they know they're hypertensive or they're diabetic. We don't necessarily need to screen them again. The screening is for people who do not know their status.
Oh, so automatically those in the rural areas will follow that this category of those who have not been screened in the past. What are the strategies mapped out to ensure that they are also reached out to and they benefit from this initiative?
So in Ogun State, we've been very strategic and methodical about our screening program. We have screening points, over 500 screening points, and every flagship PHC, every ward has a flagship PHC. All those PHCs are functioning as screening points, primary health care centers. And from those primary health centers, we have teams that go into those communities as well. So the people in the rural area are well covered either by coming to their primary health centers or our teams that are out within the neighborhood, within the community, within the market. I know, was it 2 days ago, it was Oludo Market, we were there. There's a market going on in Shagam, in Nigeria right now. My team are there, they're sending pictures in. We're everywhere. We're at the NYSC camp, we're in our tertiary institutions, Agorway, at the bus stop. We really would like people to come out. Today, incidentally, is day 4, which is right in the middle of the campaign. But unfortunately, what we have is we only have been able to screen like 50,000 out of our desired 350,000. And that is not because we don't have the teams out there. It's because not enough people are engaging with our teams. So that has prompted me to come out today to appeal to our people, as many as possible. We're going to be screening in churches on Sunday. We're going to be at the mosques tomorrow. We're continuing our screening over the next 4 days to ensure that no one is left behind. So I urge us all as good citizens of Ogun State that we come out, we get screened. What is the benefit for us? The benefit is that You know, if you're normal, then you can carry on with your normal life, and you also get some health promotion information, which is how to keep yourself healthy and continue to live healthy. You mentioned earlier on that is any of it reversible. Hypertension can be reversed by lifestyle changes. Diabetes can be reversed by lifestyle changes. However, that is if you catch it early, and that is what we're trying to do. If it's gone beyond early detection, then that means you're going to need medication. For instance, if your hypertension is mild, we can say reduce your salt intake, lose some weight, do some exercise, get enough sleep, drink more water. Those things, lifestyle changes, changing your diet would actually improve your indices as far as hypertension, and particularly diabetes. You can reverse if it's adult onset diabetes. If you lose weight, you cut out the sugar, you can then start reversing the cycle and, and bring your sugar level into control before it starts to damage your organs such as eyes, kidney. A lot of Nigerians are requiring they have kidney failure. That's because of untreated hypertension and diabetes and bad drugs. So there are lots of things that we can prevent. Early detection and prevention is the cheapest form of healthcare.
Okay, can there be any age bracket? Because I'm made to understand that you've said it now, the two are reversible. But is there any age bracket that if peradventure one is around 40, 45 or 50 before you get either hypertension or diabetes, it is not reversible any longer? Is there anything of such?
It depends on the cause of the hypertension, of course. If it's familial hypertension, some families are prone to hypertension. If it's familial, there might be the fact that you have to use medication. But if it's due to increased weight gain, you could easily lose that weight. If it's due to increased salt intake, you could easily cut the salt out and control it. Even if you can't reverse it, you can control it and make it manageable. That's why we said, know your number, control it. And there's no age range, because in Nigeria, there's some people that in their 30s that develop it. Most people develop it after their 50s, and that's because the blood vessels become thickened and they don't expand. They're like pipes, rubber pipes. And if you eat the wrong things like fat, and the fat lines your rubber pipe, the rubber pipe can't expand. So it then becomes stiff and leads to hypertension and then eventually stroke. That's why when there's a surge in the blood pressure, when it can't expand to accommodate that surge, it ruptures that pipe, you bleed into your brain, and then you end up with a stroke. So that is why it's very important. We want to avoid those chronic illnesses, because it doesn't just affect the person that has the stroke. The person might be the breadwinner, the carer that might, will be affected, because then they can't go out and make money because they have to care for their loved ones. The children will end up being out of school, or, not get their education because there's nobody to fend for them. And ultimately, it just causes heartache that we don't need to. For us as government, what this exercise will help us do is to collect enough data about Ogun State people. How many of us really are hypertensive? How many are diabetic? And then we can start to plan what, the equipment that we need, the healthcare workers that we need, the number of hospitals that we need from now till we can project into 20 years' time. If we're picking up people in their 40s that have hypertension, then we know that the likelihood that it's going to get worse in the future, another 20 years is there, then we can provide the necessary health services and plan for it adequately.
All right, thank you for this extensive explanation. But a lot of people out there want to quickly ask that, okay, if we come out and we have been screened free of charge of both hypertension and diabetes, the most important aspect of it is the management of it now. If anybody now has it, and you will agree with me that the economic reality in the country today is not that friendly, pocket friendly with people. Would there be any support of medication to people, or a subsidized drug rate that they can enjoy once they are diagnosed and they have it already, or they have to go and fend for themselves?
No, so Ogun State is one of the 2 states in the entire Nigeria that has been running what we call Nigeria Hypertension Control Initiative, where the hypertensive drugs are subsidized. We've been running it since 2020, but we still don't have people coming out. And what this would help you do is tap into that opportunity. Of course, it's subsidized, it's not free. For those that are vulnerable and are already on a basic healthcare provision fund, that's the free insurance scheme. They can easily get their drugs from that insurance scheme. But long run and the sustainable way of ensuring that you have your medication and it's not costing you any a lot is for you to sign up to the insurance. It's best to sign up before you become hypertensive, because when you become hypertensive, then you are what we call adverse selection. And most insurance companies will not take you on, even if it's private, because you have those pre-existing conditions. But in Ogun State, at this point in time, we're not applying that rule, in that we're just going to let people sign up, but sign up before you get diagnosed, because this is important for us to take care of you and ensure you don't develop all those complications.
Okay, but I bet your Commissioner of Health, you can't hit the target, the mark of 350,000 in Ogun State. As you have said, this is the middle mark, and you have just had about 50,000 people, and that means about 300,000 to go. What will happen after November 3rd? Are you going to extend the period, or there will be, it's going to be a periodic thing, that is, it will come up later in 2025 or thereabout, so that you can hit the target of 350,000 in Ogun State and 10 million in Nigeria?
So the campaign is for 7 days, and once the campaign is over, the free test would not be available anymore. So I would urge everyone to come and have themselves tested, particularly that diabetic test. The test in itself is like 200 naira each, and we're giving it to people for free. I think we should thank His Excellency for providing the funding for that. If you come after the 3rd, you'll have to pay that money. And the cost of the, what do you call it, the disposable things, you know. Okay. Not just the test, you pay for the cotton wool, the spirit, and all those things, and they all come to a significant amount, and the health workers' time, if you come outside this period. So the commodities, that's what I was looking, the word I was looking for. So it's important we come. We're hoping, as a group of commissioners, that we should be able to repeat this campaign next year. Okay. But next year, what we would be hoping to do is to screen another 10 million people. We said we're 200 million. Okay. So we're hoping to screen 10 million each year, not to go back to the 10 million that we didn't screen the year before. Okay. So we want 10 million people out. In Ogun State, we are pleading with people. We've still got 4 days. There's plenty of time. We can screen over 100,000 a day. We have enough teams out there. So please come out. Let's support this exercise that the Excellency has graciously provided for the people of Ogun State to ensure their health is maintained.
Okay, you are a health professional, and this has been your calling for decades now. Will you say, with the present economic reality in Nigeria, the circumstance that we found ourselves in this part of the world, are Nigerians susceptible to hypertension and diabetes? If no, what could have precipitated it? And if yes, how can Nigerians begin to control and manage it?
So there's a lot of research worldwide that has shown that people of black descent, the black race, we are at risk of hypertension and diabetes, regardless of the economic situation. But when it comes to hypertension, we know that stress is also a precipitating factor. And combination of our predisposition to hypertension genetically and the stressful environment in which we live in. It could be financial stress, physical stress, you know, driving long distance in the traffic to get to work, worrying about making ends meet. All these things accumulate to actually make us very high risk. Some quote as high as 30% of us having hypertension. And with regards to diabetes, our diet and our genetics also may predispose us to it. And the two extremes, unfortunate, of the sort of nutritional, because it's a nutritional disorder. There's the extreme of people who are overweight, eating the wrong things, particularly the Western lifestyle of all the burgers and things that way, rather than eating natural foods. And there's the other extreme of people who are actually underweight. But even if you're thin, it doesn't mean that you cannot be diabetic, because diabetes is a hormonal problem that comes from the pancreas. It's not about diet alone. So it's important, particularly if you have a relative, father, mother, sibling, distant relative that has developed diabetes in the past or hypertension, please come out to know your number and make sure that your number is controlled to avoid any avoidable deaths or complications.
Okay, there's a misconception out there that this project you're talking about, project 10 million, is being bankrolled by federal government, but and there's another version that says that the state governors have supported their commissioners of health to embark on this. So who is actually bankrolling it, and to what tune is the amount that you have envisaged for this particular initiative?
Yeah, because the exercise is a combination from the Governors Forum, and you know that there is no Commissioner of Health that can implement any project without the governor releasing the funds. The Honorable Coordinating Minister, in his wisdom, also has supported all 36+7 by providing us with commodities, the blood pressure machine, some, about 50 for each state, just to supplement what our governors are doing. That's about what has come from the federal government. In Ogun State, we have, as I said, over 500 teams, and each team was, so that's sort of 10% of what is required. And His Excellency, there's no cost to it because the commodities are being used from what we've procured for the use in our facilities. As I said, they're coming out of the facilities and they will be replaced as we do it. If we projected for 350 and we'd invested and only 50,000 come out, it would be a waste of public money. So we replenish as we consume.
Okay, now let's look at it from this perspective again, that if government is doing this right now, you just talk about the coordinating Minister of Health supporting all the states to carry out this by providing some essential tools, commodities to carry it out. Does it not then suggest to us that Nigeria is more than capable of running free healthcare for her citizens?
I think that's a misconception, if I may say so. Even the countries that have tried to run free healthcare have run into problem now. Not being the National Health Service of the UK, which I've worked in. For many years, I think for over 50 years now, they've run a free healthcare, but it's run aground now. They can't meet their services, and it's now just a political issue which government is going to decide they're going to start charging. States like America run both, and even the Medicaid for the vulnerable has its challenges. In America, everything is paid for by insurance. But even in England, the free at the point of use is what you would say. It's never free. The British health system is supported by the taxpayers' money because they deduct what you call NI, National Insurance, which is for your health, for your road, for electricity. They deduct that from source. And when I was working there, 40% of my salary went on my national insurance. So people have to pay. Nothing is free. Someone is paying somewhere. And unfortunately, we Nigerians, we don't pay tax. So how does the country fund its national insurance, its health service? And the important thing now is to make sure that we all buy our insurance. That's our own little way of contributing towards a bigger pot, which then anybody, any one of us that needs the service can then take out of. As I like to call it in Yoruba, it is Ajo Ilera. Okay. That's a collection for your well-being. And when you know when you do Ajo, it's only one person a month that carries the Ajo home, not all the people collecting. Everybody takes it turn by turn. And that's how insurance works as well. Because not everybody that pays the premium will fall ill, but when the person falls ill, there's enough in the pot for that person to get the best care that they want, from the right person in the right quantity.
Okay, now, this project that is ongoing, now I would like to know, there are 20 local government areas in Ogun State, 236 wards all over. Now, have you been able to deploy the teams? Is it evenly or it is lopsided to a particular area? Lopsided in the sense that if you take, for instance, Ota, Abeokuta, Ijebu, these are heavily, or let me say, highly populated areas, that more people live in these areas, they work there, and the likes of that. So have you been able to distribute these teams in order to reach out to get to the grassroots? We
run a health system, and we're the same people that did the COVID vaccination. We're the same team that go out and vaccinate our children about 3-4 times a year. So we know exactly how many people reside in every local government. We know exactly how many, wards, what the wards distribution, which Ewekore is one of our small ones, whereas Odeda does not have population, but it has landmass. So that will require extra deployment of teams because they have to travel further to get. Okay. So we distribute them with equity, with precise. I told you we're very methodical and equitable about the way we've done this. So Ota will have several teams because Ota has almost 1 million people in Ota local government. Right. Abeokuta South too has about 800,000. So we know, and I'm reeling this out off my head, and you can go and check. So we know where people are. And we've designated our staff to reach out to them, as many as possible. It is in our own interest as well that we catch as many people. But it's important they come to us. It's more expensive if we go to them, because then we're moving from one house to the other. But if our staff are in a fixed point and people come to us, it makes them more efficient. The time that they'll be spending moving around, they're taking blood pressure
more people.
So we would prefer people to come to us.
Okay, so how do you want to carry out that of Friday, tomorrow, November 1st, and Sunday, November 3rd, when you say we are going to be at mosques and churches? And definitely you can't be at all the churches and mosques all at the same time. So there will be a designated point. And so how do you want to achieve that? Because Nigerians are perception about issues. Why can't they come to our own area? Why must I leave point A to go to point B to have it?
So all our PHCs would still be open. So the PHC in your area will be open to take your blood pressure as long as you walk into it. We're not stopping the services in the primary health centers. Okay. So it's our teams that are roving that would move to the larger worship centers. So if there's a central mosque in that locality, we'll go and sit in the central mosque.
So like Abeokuta, we have Kobiti?
Exactly. So there will be at least maybe 200-300 people in one place tomorrow, and we can capture that. But it doesn't mean which local government, which ward is Kobiti in?
Kobiti is, I don't know the ward, but it's under Abeokuta South.
So there are other PHCs in that area that will be functioning. So the other people that are not in the mosque can go to the PHC and have it done. If there's a market going on in that ward as well, there'll be a team in a few teams in the market to actually take blood pressure.
All right, we saw the number one citizen in Ogun State, Prince Abeokuta, had his own BP and the rise.
Yes.
His cabinet members, have also taken advantage of this?
It's interesting you say so. We're screening everybody in the government office. We go from MDA to MDA. So each MDA has their own day just to make sure that we cover everyone and people don't have to leave their work and queue. To make it more efficient in the government office, we've given them days to come out to get screened. Okay,
now let me quickly digress into this before we come back to the issue of Project 10 million. You had an interface with a federal government agency today, the National Emergency Medical Services and Ambulance System, with that of the state. And basically they are looking at how they can percolate or how they can go more into the rural areas, in the area of maternal health and the likes of that. How visible would this be? What are those things that you came up with at the interface today?
So the national team, NEMSAS, has come to collaborate with us because we are already running the system. There is we launched that on the 19th of September in Odeda local government. Because of want of resources, we thought we'll try it out. And on a national level, as they mentioned in the interview, it was a success. And they've come to support us in expanding it to other local governments, particularly 30 communities where maternal health, maternal mortality is high. And that would be across 6 local governments, 2 in each senatorial district, to provide us, hopefully, with some ambulances, some support, some training, so that we can extend this service to other women, particularly in the rural area. Because we know there are 3 barriers to women accessing the health facility during childbirth. One is not being aware, and cultural issues. The 2 is actually when they do want to go, they have no means of transport because they are far from the PHC. The last one is financial bottleneck. That financial bottleneck has been addressed by His Excellency Prince Abeokuta through Ibidero, the free insurance for pregnant women. That also includes a 5,000 naira incentive. Once they deliver within the facility, we give them 5,000 naira. And you know what? Go and buy something for yourself and the child to help you start the child's life. We know that it's not financial issues that are still stopping our women. So we're hoping that by providing the free transport, we'll see more women attending antenatal clinic. We'll see more women having their babies in our facility. And with that, over time, we're hoping that there will be a decrease in the number of women dying from unnecessarily from childbirth. That is so important. There are nations where the maternal mortality is 7 per 100,000. It's still, Ogun State is still the better performing one. It's 280 something per 100,000. But that's not good enough. We're hoping to get it down to, double digits, single digits with time.
All right. Okay, for the screening, the free screening, it's like a gateway. In fact, that's the appellation of Ogun State, gateway to everything. It has a border with international border and local borders as well too. How are you also taking care of this? Because a lot of people, particularly when you look at the border areas, Mowe, Bafo, Ojodo and the likes of that, people live in Ogun, but they work in Lagos. So when they come in, are we also going to capture them into this Project 10 million so that you can be reassured that you are having a healthy and a more good people living in Ogun State, rather than people that will be susceptible to health challenges and the likes of that?
No, the truth is the border between Lagos and Ogun State has completely disappeared because of the fluidity. 20% of Ogun State citizens actually work in Lagos. So our focus is not where you live or where you work. As long as you're within our borders and you present yourself, we'll capture you. What I was thinking you were going to ask us is how do we make sure that the same person is not captured twice? And we are heavily reliant on the electronic medical record. So all data are captured electronically.
Oh, okay.
And it's sent straight to Abuja. It doesn't even sit within the state. That is to ensure that states cannot manipulate the number of people that they've screened, and we can get a true picture of the number screened and the data coming. So reliable data which can be used for resource mobilization and also policy making.
Okay, let's go more on the issue of education, so that viewers out there can also learn more. A pregnant woman that is diabetic, is that child also likely to have such, or it is not likely to get it or be to contract diabetes while still in the womb and the likes of that?
So a pregnant woman that is diabetic, there are two types of diabetes. Some women are type 1 diabetes, which means their sugar has been abnormal. It has nothing to do with the pregnancy. It's just that they're being diagnosed during pregnancy. And there's the other group called the gestational diabetes. With the genetic one, there's a likelihood that that child could develop diabetes later in life. With the gestational diabetes, it's the hormones in pregnancy that has put pressure on the woman's pancreas to start producing insulin, insulin, and that actually, the child may not develop diabetes inside the womb, but the child could be obese if the sugar is not controlled. So those are the women that end up with 4 or 5 kg babies, whereas they're only tiny. So it's important to get that controlled, and also after the child is born to ensure that they have a balanced diet so that the tendency to develop diabetes will not be transferred to them.
So it is not hereditary?
If it's gestational diabetes, it's not. But if it's diabetes that is pre-existing but was picked up in pregnancy, then it could be hereditary.
Oh, okay. All right. So as we move on with this free screening, do people still need to still go out there after screening, being screen free now, and still possibly after a year or thereabouts still need to go for periodic checkup to know whether it's been controlled or not?
If you are above the age of 50, I would absolutely suggest you have, and even 45, annual checkups of your blood pressure, of the diabetes, of your sides. For men, PSA, that is the hormone for the prostate, because it's not uncommon that men develop cancer of the prostate without knowing. And for women, they have to have their yearly checks, have their breast examination, cervical smears. So any one of us above 45 must have those annual checks. People younger, if they have normal blood pressure, they can live their normal lives, but have periodic checks as their body dictates. But however, after 45, you can't afford that haphazard.
Oh, it has to be annual.
It has to be annual. If you know, and as you get older, you know, if you're in the 40s, you might want to do it every other year. But annual is the best practice.
So we wouldn't say it is wrong for somebody like me that checks my blood pressure almost on daily basis, because
there's nothing wrong with that. That's minimum. Annual is minimum. If you want to check it every day, if you feel you're at risk of developing blood pressure, then check it. But if you're not at risk of developing high blood pressure, then doing every day might be a little bit on the excessive side. But if you are on treatment, you need to monitor it, and that should be on a daily basis.
Can you break it down? Because I understand there is hypertension, there is hypertension, there is stage 1, stage 2. Can you break down the figures so that people can know that once you check it, you begin to understand that, oh, I'm getting to a level of being hypertensive, I need to control my food intake, whatever, or your lifestyle and the likes of that?
So normal pressure, and normal blood pressure is between 100 to 120, the top bit. And the bottom bit is between 60 and 80.
Okay.
So if your blood pressure, if you're fit, your top one could still be 90 and you're fine. But if your blood pressure starts dropping, particularly the lower one to below 50, then you could be hypotensive.
Okay.
Hypertension is not, you find it more in people that exercise because they've exercised to the point that their body can tolerate that. But hypertension is the one that really matters. I'm going to go to hypertension quickly. Hypertension that makes you faint, if your blood pressure drops too low that you faint, is bad. You need to get it checked. Okay. But if your blood pressure is low and it doesn't cause you any problem, that is your norm and you can live your normal life. Hypertension is the one that we're very concerned about, and that's if your blood pressure goes above, you have mild hypertension, which is about 140/90. Okay. So if the top one is 140 and the bottom one is 90, that is mild hypertension. But if you start getting 150/100, 160/100, then 160/110, sorry. Wow. 160/110, that is severe hypertension.
Sure. Okay.
So you have in between that, you know, you can still control it. But 160/110, you need, it's an emergency. You could actually rupture a vessel. You need to get immediate attention. But if you're still hovering between, you know, 100, 90, 100, 140, 150, you need to go back the next day, get it checked before the medication starts. So for you to diagnose hypertension, you need 2 readings of the blood pressure, at least, 1 hour apart, with the person in the rest position. Okay. So if you get someone that is high blood pressure whilst they're rushing around, you tell them to sit down and take it an hour later. If it goes back to normal, then you know it's the activity that is causing it. But if it's persistently elevated, then you know that they're hypertensive. However, and I want to repeat this, if it's 160/110, that is hypertension without any doubt, and you need immediate treatment.
Okay. All right, you said something so scary, the issue of if you exercise regularly, then you can invite, let me use that word, invite hypertension. So
hypertension is not a bad thing. Okay. It's just, as I said, your blood vessels are elastic. If you exercise, then your blood pressure could be, for instance, mine is 90/60.
And being consistent like that?
It is, because I exercise every morning.
Okay, let's take a look at.
So it's not a bad thing, as long as you're not fainting. If you're fainting with a blood pressure like that, you need to get it checked.
Okay, so that means this group of people, the athletes, those are engaged in 100 meters, 200 meters, which they do regularly. So are they also likely to contract hypertension?
They can, if they've got a genetic predisposition to it. So if they have a family history of hypertension, they can, despite running every day, despite being very thin, they can develop diabetes as well. So it's not, it's not just exercise, a combination of your genetic predisposition, the diet, exercise, sleep, lifestyle, stress. And a lot of us don't know how to de-stress. Some of the things is, hanging out with friends, exercising. For me, I like to play golf, and that takes the stress off. So people have to find where they can distress.
Are the two like Siamese twins, that is hypertension and diabetes? Because I also been made to understand that once someone has hypertension, that person is likely to have diabetes.
They're not Siamese twins. However, the predisposing factors to it, the things that make you likely to develop hypertension, are also the things that make you likely to develop diabetes. That's being overweight. That's your eating habit. If you eat badly, you're likely to be overweight. You're likely to eat too much salt. Like if you eat processed food, there's a lot of salt in processed food. So that can, Also, if you're not exercising, if you live a sedentary life, you just sit there all day in front of TV, you don't move around, you want to pick the cup next to you, you're asking someone far away to go and get the cup. You know, you need to do things for yourself. You want to turn on the TV, get up and turn it up. What I tell people is keep moving. We are created as human beings to move. And if you don't take up to 10,000 steps a day, you're likely to become obese. And most of us, we have sitting jobs, standing jobs. We don't walk around. So that predisposes us to that.
So are you encouraging in any way that this initiative of Project 10 Million is another inroad into helping Nigerians to manage their health very well?
Absolutely. One of the key focuses of this Project 10 Million is health promotion.
Okay.
So we don't only check your blood pressure or test your sugar, we give health talks so that when people come, they know if they have good numbers, how to maintain their good numbers. If the numbers are borderline, how to get it back down to normal. If the numbers are abnormal, what to do to actually improve it. That's the health promotion aspect. So then there's the early detection, which means that when we detect these things early, we can intervene, control it, and avoid the complications which can lead to long-term illness. And so without any doubt, I am encouraged, be it only 50,000 people up to today, that that is 50,000 people that yesterday might not have known what their numbers are, but they are aware. And I'm sure for the hypertension, there's about 14% of them that are hypertensive. And I'm sure those 14% now know what to do to help them control the hypertension.
And avoid sudden deaths.
Yes. So I am very hopeful that it would have the impact that we're looking forward to in improving the indices.
All right, now, Commissioner, from the reports we are getting from the field, now 50,000 people so far have been captured under this Project 10 Million, of which 350 is assigned to Ogun State. Now, do you think from the reports, maybe there are things that you are doing that you're not doing right, that you need to change the direction, change the perspective so that you could have more people coming out, because you can't keep doing something the same way and expecting a different result. So what do you want to say to that? How do you address such?
Well, I'd like to hear that feedback from you, because you said from the field, because we on a daily basis, we actually sit 9 o'clock, 8 to 9 every night. We look at every team, all 500 teams have a code. So we look at, if I open my phone, you see how I know exactly how many each team has done, where they have gone to, which community they have served. So we on our side, as the state team, we are analyzing data. And if you use data, data informs your action. We're not doing this blindly. And that is what has informed me to come back out to talk to people, because we have the teams there. People are not coming. What else could we do? We've done mass communication. We've gone on radio. We know that majority of Ogun State people listen to radio. We've gone to radio. I was here on TV last week. My director was here on Monday. So we keep engaging. We've had advertisement in papers nationally, you know, and it just seems that it's the people's health-seeking behavior that is has cause for, you know, questioning, because we pretend that nothing is happening. We like to bury our heads in the sand and hope that it goes away, because we don't want to know. Sometimes they literally say people run away from them. I don't think we should be running away from the health workers. The more we know, the better we can control and avoid what we're pretending that we're avoiding by burying our heads in the sand. So I think we're pleading with the public to please embrace the screening.
Or peradventure, we say we want to attach a free distribution of food items, maybe that will invite people to come out.
But even if you attach free distribution of food item, you know what's going to happen is their blood pressure is going to go up because they'll fight over the food. Just that's the joke. So we don't want the food attached because our readings will be upscale because the excitement of the free food will be too much and that their blood pressure will skyrocket.
Okay, let's go into this area as well. Approach the last leg of the program. The issue of ITN, insecticide treated net, and Ogun State is presently having one now. They were here in 2021. They are back again 3 years after. Is it that Ogun State has a high prevalence of malaria record, or what, or why are they back? And what advocacy has been put into this to ensure that people this time around, they should come out, get the nets and use it for the purpose?
So the ITN campaign is it's funded by the Global Fund that funds, quite a few states in Nigeria, where the prevalence of malaria in Ogun State is 22%, which means 1 in 5 of us would have malaria at every given time, which is rather high. If you saw in the news last week, Egypt, an African country, was declared malaria-free. They've eradicated malaria just as we eradicated polio. So if Egypt can do it, I'm convinced that Nigeria can do it, and we could start from Ogun State. But the ITN campaign comes around every 3 years with nets that are treated with insecticides. When you look at malaria control, there's several factors that affect it. So there's the use of treatment for insecticide treatment for control to avoid people being bitten. But we also need to look at the things that we can do to reduce mosquitoes, which are the vectors in our environment, clean environment, no gutters, overflowing gutters, cutting the weeds back. Those would avoid, the breeding places for mosquitoes around us, not to talk of them coming to bite us, which is what the net is preventing. So we distributed 3.6 million in 2021. So Ogun State is estimated to have 7.1. So they actually calculated 1 net to 2 people. This year, they're distributing 3.1 and a bit. And that is because they've looked at the utilization rate of the net and found that the people in urban areas, when they go to distribute the nets, they're not there. The gates are locked, they can't approach them. So it becomes wastage. So they've kind of pulled back from, like Abeokuta South, there's only one ward within Abeokuta South, which is Itoko, that's going to receive the net. But in other LGAs, we're going to be actively there. And it's a two-phased approach. In 2021, due to COVID, we went, enrolled the people and gave them nets at their doorstep. But this time around, they're going to mobilize them, give them a net card. So you collect your card, then about a couple of days later, they'll announce you go to the distribution center to pick up your net. But what we're appealing to people to is to avoid environmental contamination, because to be, environment aware, to create environmental awareness, is that you bring your own nets so that we can dispose of them properly. Because people use their old nets for all sorts, but we find that net is found in fishes, and it's contaminating and killing the natural livestock. So we are hoping that this time around we're combining technology. The technology, there's some LGAs, 3 LGAs, where they're going to do e-net cards, e-token. So you don't have a paper. It's just they put it on your phone and you take it to the place and they scan it and they register that they've given you. And through that, we can also monitor where the distributors are. If they've gone to every household, we can, if we look at the map, expand the map, we can see which area, communities have not been attended to on a daily basis. So this ITN campaign this time around is very technology oriented and environmental friendly.
Yeah, I'm so happy that you mentioned something about my local government, Abeokuta South. Just one word. That means the prevalence is low in Abeokuta South.
It means that
Despite
you're very rich in Abeokuta.
That malaria is not common.
It's not. It doesn't mean that malaria is not common, but you're able to afford to buy net. You're able to afford to buy sprays, and we're hoping that your environment is clean as well. Compared to
that we have been able to achieve that as well.
Yes, yes.
Oh, okay. All right. So, project 10 million as we round off on the program. The governors, peradventure, like in Ogun State now, our own governor here is on a second term, some governors are on first term. Will it be a continuous exercise? That is, when new set of governors find themselves in office, Edo, for instance, will be installing a new governor come on November. So would they also be part, would they join this train to make sure that health status of Nigerians are well known and is being well managed?
The thing is, government is a continuum. And this is a health exercise, and I think it transcends political landscape. It's owned by the Commissioners Forum, which is a forum that is in perpetuity, and the Federal Ministry of Health, and the Governors Forum. So those fora would still be in existence regardless of which governor or commissioner is there. And our hope, because this is the inaugural campaign, our hope as commissioners is that the minister and the Federal Ministry of Health would take this as an annual event, and we're hoping that the partners, our development partners too, will collaborate with us so that we can do this. It's never been done. It's unprecedented across the world.
Oh, this is the first time it's happening in Nigeria?
First time in Nigeria, in Africa, in the world, that commissioners have come together and said, for the next 1 week, we're screening our population for free. No other nation has done it. So it's a first for Nigeria, and we're wishing ourselves a very successful campaign.
So you can boldly beat your chest and say you have been fulfilled and being Commissioner for Health in Ogun State at this material time in Nigeria? Absolutely.
I'm extremely excited because Nigeria is going through a transition period in its health system with the coordinating minister who is there at the moment, who's a physician, well-seasoned physician, a lecturer. He's worked with development partners, the World Bank, and so he has, with the, the president's vision of actually transforming the health landscape in Nigeria, he's implementing it with a strategy called sector-wide approach, which means that we do things in collaboration with the partners, that we're no longer working in silos. And with that, if you look at the health landscape in Nigeria in the next 5 to 10 years, you won't recognize it because there's a lot of investment, resource mobilization, training, equipment, just revitalizing the entire health sector.
All right, thank you so much. That has been a wonderful session with Commissioner for Health in Ogun State, Dr. Tomi Koka. We talked about the issue of the project 10 million, and not only that, we have also talked on the issue of ITN campaign that is ongoing in Ogun State right now, and of course the other issue of maternal death and the likes of that. We have also talked about that on the program, so we want to appreciate you for finding time to share your thought with us on the program as well too. That's how we draw the anchor on this week's edition of the program, Democratic Part. I remain to the show. I'll be back next week, God willing. Keep flourishing the peace of the Most High. Bye for now.